Thank you.
like.
Thanks. I was just noting, I think, Pat, your student has been based upon that quotation, has been a student of our system of government, I think, right? Ignorance with passion. That's going to ring for a long time.
I think there's a lot of informed on dead ears, too.
Oh, boy. So we, again, as was said, we focused on working with patients to assess communication among health providers and health professional learners. And I will say that, although it's an overused expression, I think it was a bit like herding cats, because of all of the four, I think we are sort of most rudimentary, if you will, or most beginners in this notion of how to work with patients to assess. Almost working with patients to assess almost sounds oxymoronic in a way. What do you mean? How could patients help us assess? So that was reflective, I think, in the kind of more brainstormy nature of our interactions, which was fine, and as soon as the facilitator got used to it. So the challenge we defined was, or that we decided to think about was, after getting lots of them, was to expand the role of patient experience to assess communication of the team, which sounds an awful lot like what we were ordered to do, so it was nice and consistent. The macro level suggestions we had were which is an ongoing process, to develop a qualitative dimension to CAPS. I think the overall underpinning for a lot of our conversation was about how to capture the very important patient narratives, which, because they're so big and unwieldy and not systemic in the same way that quantitative data can be, or outcomes data, get lost, and that we need to rededicate ourselves to figuring better ways to not lose that valuable input. And we need to engage patients in doing all of this, which is kind of what's happening. Develop an expanded participant base for CAPS to include family members, caregivers, and others, because patients alone are probably not all we want to hear from, or all that makes sense for us to hear from. And to add patients to the certification system, but be sure they're not conflicted patients, like putting retired hospital executives on the is probably does not represent the patient voice in a way that seems important to do that. Well, you laugh, but I was asked to be on the board of an FQHC, and they asked me if I would consider getting my dental care there, because that would make me a patient representative instead of a community representative. So it happens, I think, all the time. Also, be sure there's diverse representation, and of course this is an enormous challenge, but just kind of anecdotally, I'll say that I think one of the things that's really cool about the various different methodologies we tried, I think, in the course of this workshop, was the realization that if you're going to engage a new population, you need to change the way you interact with each other, because people won't be able to just fit in. They don't feel, I don't speak the language, I don't understand the discipline, but I'm a lawyer and a teacher, so I'm basically willing to get into any conversation. But most patients won't be, so we really need to think about, when you're inviting someone into your home, you don't just let them come to the door and say, come in, get what you want in the refrigerator. You make some preparations for having them there, and engaging patients at any level is going to require some thinking about how to change how we run meetings, how we interact, how we, the most fundamental things. So. Meso-level opportunities for institutional change, exploring utilization of health electronic records, EHRs, sorry, that was a typo, to get input from patients on their care experiences. Bring patients together in groups, so there's safety in numbers. We talked some about patient advisory councils, but also at the clinic level to assess care experiences, perception of workplace climate. You'd be surprised how much your patients know about the workplace climate. And those of you who run healthcare organizations should be dying to hear from your patients about the workplace climate, because they know a lot, and they know a lot more than you probably get told. So that's a really, really important, I think, suggestion. And then micro level, using waiting room time to educate patients. How many of you have been to Disneyland or Disney World recently and seen that when you get put in a 40-minute waiting line, they've figured out how to entertain you for 40 minutes, so that you're not standing there going, God, this line, it never moves, and blah, 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 blah. they use your time. So using waiting room time to educate patients interactively about whatever, about how to provide feedback, what's useful, how it'll be used. And we talked a little bit yesterday about how, in one of the groups, about how engaging patients in design, redesign, clinic, that has a crossover impact to engaging them in their own health care. So, and likewise, engaging patients in their own health and healthcare has a crossover effect that they get interested in how it gets delivered. So if you have patients that you think are, for whatever reason, or populations that you think are unable to get interested in their own healthcare, sometimes I think of sort of mothers as this, like the only people they can care about are others, right? So if you want to get your moms involved, ask them to help you teach people, because they can't resist being asked to help do something. Okay? So there are, and then you get them engaged in helping you teach people, and they become interested in their own health care. So I think it's got this bilaterality that is a really valuable thing to take advantage of. Compensate patients for sharing their experience, and compensation can mean a lot of things. It can mean a gift certificate or cash or something else. And it can also mean explaining to patients the value of sharing their feedback, putting it in your organization newsletter, your institutional newsletter. Look, we have this group of patients who's really helped us, and we did this, tell stories, tell their stories, get their information, and then use it. I mean, there was a lot of exasperation, I think, expressed about how we gather all this data and we don't use it. And it is really important to turn that around, so to have a plan for that, both for individual learner improvement, for system improvement. We had 4 overall strategies, and we can pick one, or I liked group 1 having like a lot of strategies, so I would wipe out that pick one and say this was some highly well-linked set of 4. But I do think actually that in a way what we came up with were strategies. The individual institutional level was take data that's collected and engage patients proactively. So that's kind of both individual and an institutional level one. Engaging learners as part of the data collection and helping them figure out how to use it to effectuate quality improvement is an individual level strategy. Have this group, the IOM Global Forum leadership, communicate to a wider audience a shared vision of the importance of engaging patients in assessment and share some effective models for doing that is obviously a policy level a strategy. And another institutional level, sort of more institutional level one, is use clinicians as observers and reporters, interpreters of the patient experience to help learners understand it and self-reflect in a safe environment. And again, I think your patients can be really helpful to your clinicians in providing that kind of feedback. So that was ours.
Thank you, Meg. Why don't we give a hand to all of the panel?